Welcome to Lively Live Snippets. How are you today? I hope that you are doing fine and creating moments of life which you can cherish in future. Let's throw back to March 2019. It was my second medication therapy adherence clinic, MTAC, case presentation. I had followed my preceptor who is an expert in warfarin TAC for a week. One patient who caught my attention was her INR shot up after taking a few days of paracetamol tablets, which is a very common painkiller. Without further ado, let's look into the management of interactions between warfarin, drug and supplement. Please note that any content of this video does not substitute professional medical advices. If you have any health issues, please speak to your doctor and healthcare team. This video is a sample of few presentations that I had done during my Provisionally Registered Pharmacist, PRP, training in Malaysia.
Why warfarin MTAC is indicated. Warfarin is a drug with narrow therapeutic index. INR less than target range predisposes to thrombosis and patient does not benefit from the benefits of warfarin. INR more than target range predisposes to hemorrhage, which can be life-threatening sometime. Consequently, drugs with narrow therapeutic index require INR monitoring frequently during initiation, and the frequency reduces as patient stabilized. Warfarin is associated with lots of interactions with many things, which include but not limited to supplement, herb, disease state, lifestyle, food, as well as complementary and alternative treatment like massage.
The case which I wish to present today is Miss GKJ, a 76 years old Chinese female who is not working and claimed not to have any no drug or food allergies. She doesn't smoke, drink alcoholic beverages or abuse recreational drugs. She is unmarried and stays with her mother and sister. She was diagnosed with hypertension and hyperlipidemia in 2006 and multiple gallstones in April 2018. She was diagnosed to have atrial fibrillation in the 26th of March 2018 and hence started on warfarin.
She was prescribed atenolol and amlodipine for hypertension. The dose of atenolol has been reduced from 50 mg to 25 mg in 2016, while amlodipine has been increased from 5 mg to 10 mg in 2015. Her lovastatin had been switched to simvastatin 20 mg until today. She claimed to be compliant with her medications. She had been taking Neurobion tablets 1 tab once a day and mecobalamin 500 mcg 1 tab once a day. Both vitamins were prescribed by private neurologist, and she claimed they improved finger numbness after completing 2 weeks course. She accidentally sprained her knee and she took paracetamol 500 mg 2 tablets 3 times a day for 5 doses. Then followed by 665 mg 2 tabs 3 times a day for another 4 doses on the 24th of February and the 25th of February. She also applied ketoprofen 2.5% gel twice a day whenever she felt pain. Both the paracetamol tablets and ketoprofen gel were self-purchased from pharmacy. She also took coenzyme supplement at a dose of 60 mg once a day since 2018 because her relatives persuaded her that it had heart protective effect. Supplements was withheld for 2 periods of time due to stock issue. If there is no stock issue, she claims she took the supplement every day.
Since the initiation of warfarin in March 2018, the dose of warfarin had been slowly adjusted to reach a dose of 1.5 mg once a day from Monday to Friday, 2 mg once a day on weekends to reach a target INR range of 2 to 3. However, the INR fluctuates instead of stabilizes. Patient came from TAC appointment on February 26, 2019, the INR shot up to 4.5, possibly due to painkiller usage due to her sprained knee. On the day of visit, warfarin was withheld for 3 days and patient will come back later with an INR of 1.5. Since the INR value fell below subtherapeutic levels, warfarin was resumed by doctor at her usual dose for 1 week.
Patients was deemed to demonstrate good compliance as she claimed did not delay or miss any doses of warfarin for the past 2 weeks from 12/2/2019 to 26/2/2019.
In terms of lab investigations, her full blood count and thyroid function test results were within normal range. Her chloride levels, serum creatinine and creatinine clearance, were slightly deranged years ago. Her liver function tests and lipid studies did not have any outliers. CHA2DS2-VASC score is used to determine 1-year risk of thromboembolic event in a non-anticoagulated patient with non-valvular AF. This patient scored a 4 because she had hypertension, aged 76 years old and is a female. A score of 4 points means stroke risk was 4.8% per year and 6.7% risk of stroke to systemic embolism. As her score is more than 2, she was qualified as an anticoagulation candidate, with an INR target of 2.0 to 3.0.
Has-bled score is a tool used to estimates the risk of major bleeding for patients on anticoagulation and hence, to assess risk-benefit in atrial fibrillation care. Patient scored 2 points as she was 76 years old and she used ketoprofen gel, which may have minimal risk of predisposing to bleeding. 2 points means patient has 4.1% bleeding risk, or in other words, 1.88 bleeds per 100 patient years in another validation study. Anticoagulation can be considered, however this patient does have moderate risk for major bleeding, which is defined as about 2 in 100 patient years. This format of documentation was found from hardcopy warfarin MTAC protocol found at my workplace, and I could not find an online copy to share with you all. The link. 3 main sections that make up follow-up documentation are patient information, subjective information and pharmacist review or assessment plan on next slide. The patient information is as described in previous slides and fill in accordingly. Total warfarin dose per week was calculated by 2 mg multiplied with 7 days a week to give you 14 mg per week. Patient claimed not showing any signs of bleeding or thrombosis. She took her dose correctly and claimed no missed doses. The recent medications changes and supplement intake were as described in slides before this. Apart from these, she denied dietary changes. She also denied any changes in physical activity, but she sprained left knee in the past week. She was not pregnant and no other complaints. Her INR was supratherapeutic with a reading of 4.5 but no bleeding tendencies being showed. Therefore, we suggest to withhold warfarin for 3 days and further management by medical officer. We suggest to stop neurobion and continue mecobalamin tablets to avoid polypharmacy. We also emphasize to maintain current diet and advise patient to consult doctor immediately if any bleeding occurs. We asked patient to return for INR checking on the 3rd of January 19.
Our suggestions are being practiced by patient and she stopped taking paracetamol tablets but used ketoprofen gel more frequently. INR dropped from 4.5 to 1.5 without bleeding tendencies. We suggest to restart T-warfarin 1.5 mg once a day during weekdays and 2 mg once a day for weekend for a week and then check INR on the 3rd of August 19.
The first pharmaceutical issue is supratherapeutic INR on February 26, 2019. After withhold for 3 days, INR is expected to decline by about 0.26 units per day, which may range from 0.2 to 0.5 per day. If INR declined by 0.5 units per day for 3 days, INR upon return on January 3, 2019 should be 3.0. Intervention accepted by doctor and patient.
The second issue is interaction between coenzyme Q10 and warfarin. Patient resumed taking coenzyme Q10 60 mg odd after withholding for 2 weeks. COQ10 is structurally related to menaquinone or vitamin K2. This may reduce INR and increase risk of thrombosis. Upon assessment, no signs and symptoms of thrombosis. We advise patient to avoid concomitant use if possible. However, patient is very keen to continue taking COQ10. We suggest to monitor INR closely and adjust warfarin dose as needed when starting and stopping COQ10. We ask patient to inform every time she wants to withhold and restart COQ10. We also suggest patient to consult doctor immediately when having symptoms of thrombosis. Patient continued to take her T. COQ10 at the moment. Since INR is high, recheck January 3, 2019. Patient agreed to visit doctor if experience any symptoms of thrombosis. Symptoms of thrombosis include but not limited to sudden weakness or numbness in the face, arm, or leg on one side of the body, sudden loss, blurring, or dimming of vision, slurred speech or inability to speak, sudden, severe headache, dizziness, drowsiness, falling, or lack of coordination, nausea or vomiting, especially if accompanied by any of the above symptoms, headache and many more.
The third pharmaceutical care issue is the interaction of ketoprofen and warfarin. Drugs.com interaction checker showed lack of interaction of ketoprofen with warfarin. Patient apply thickly over sprained left knee. Topical NSAIDs may be absorbed into systemic circulation. Ketoprofen is 99% bound to albumin. Ketoprofen may displace warfarin and hence increases serum warfarin concentration. This interaction may prolong PT and inhibit platelet adhesion and aggregation. As a result, this may increase INR and bleeding risk. We advise patient to use topical ketoprofen 2.5% gel she had bought, when required thinly. If pain remains unbearable, start with 1 tab paracetamol and slowly titrate up according to response. Not more than 2 grams per day of paracetamol for not more than a few days. INR should be monitored closely. We also advise patient to consult doctor immediately if any signs and symptoms of bleeding occurs. Patient agreed to use ketoprofen topical gel thinly when necessary. If pain persists, start 1 tab paracetamol and slowly titrate up. Check INR. The 3rd of January 2019 patient agreed to visit doctor if experience any symptoms of hemorrhage.
The fourth issue is paracetamol and warfarin interaction. Paracetamol 1 gram 3 times a day for 5 doses and 665 mg 2 tabs 3 times a day for 4 doses, from 24 February to 25th of February. Daily doses obtained by multiplying 665 mg with 2 and then with 3 to get a total of 3.99 grams per day. Paracetamol inhibit the metabolism of warfarin or interfere with clotting factor formation. Paracetamol at 4 grams per day induce a significant increase in INR in patients who are on stable regimen and may increase INR and risk of bleeding. In warfarin-treated patients who will use more than or equal to 2 grams per day of paracetamol for at least 3 consecutive days, Renato and the team suggest that the INR should be tested 3 to 5 days after the first paracetamol dose. Hence, we suggest to check INR on January 3, 2019. We also advise patient to use topical ketoprofen 2.5% gel she had bought when required thinly. If pain remain unbearable, start with 1 tab paracetamol and slowly titrate up according to response. We advise patient to consult doctor immediately if any signs and symptoms of bleeding occurs. Patient agreed to visit doctor if experience any symptoms of hemorrhage.
The 5th pharmaceutical issue is polypharmacy of cyanobalamin and mecobalamin. Patient was being prescribed by private neurologist Neurobion tablets which contain 1000 mcg cyanobalamin per tablet and mecobalamin tablets 500 mcg once a day for 2 weeks from the 12th of February to the 25th of February. Finger numbness showed improvement. Mecobalamin is the active form of cyanobalamin. No interaction found between vitamin B1, B6 and B12 tablets and mecobalamin tablets with warfarin. We suggest to taper down by stopping vitamin B1, B6 and B12 tablets and continue mecobalamin tablets as the symptom improves. Medical officer agreed and prescribed mecobalamin tablets 500 mcg OD for a month.
The last pharmaceutical issue is subtherapeutic INR, which is lower than target range 2 to 3. INR today is 1.5 after withhold warfarin for 3 days from the 26th of February to the 1st of March. Patient followed the advice from last visit to stop paracetamol for 3 days and increase the frequency of ketoprofen 2.5% gel from twice daily to 3 times a day when required. Upon assessment, no bleeding and thrombosis tendency. Medical officer prescribed warfarin 1.5 mg once a day for 1 week. We suggest to restart warfarin at a dose of 1.5 mg once a day on weekdays and 2 mg once a day on weekend for 1 week. Suggest to check INR on the 3rd of August 19. Advise patient to consult doctor immediately if any signs and symptoms of bleeding or thrombosis occurs. Medical officer agreed to restart warfarin at recommended dose and check INR on the 3rd of August 19. Patient agreed to visit doctor if experience any symptoms of thrombosis or hemorrhage.
As a conclusion, warfarin is a drug with narrow therapeutic index. Hence, closely monitor INR when bleeding risks are high and monitor regularly, but less frequently when patient's condition stabilized. Interactions of warfarin with concomitant drugs, supplements, lifestyle, herb, complementary and alternative therapies as well as disease states prompt frequent INR and clinical monitoring for signs and symptoms of thrombosis and hemorrhage until the cause is resolved. Pharmacists play a role in educating patients and collaborate with other healthcare professionals to reduce side effects and ensure patients are sufficiently anticoagulated.
Here is the list of references that I had used. You can refer for further reading if you like it. Please note that the content of my slide was made when the latest protocol, which is Anticoagulation Medication Therapy Adherence Clinic, ACMTAC, is not yet published. Do refer to the latest guideline with the link shown in the slide. Thank you for watching Lively Life Snippets, and if you like my videos, hit the like and share button. Don't forget to subscribe and see you all in the next episode.